Good afternoon, everyone, and welcome to today's program. It's titled Integrated Care Means an Integrated Electronic Health Record. I'm Dennis Grantham, Editor-in-Chief of Behavioral Healthcare Magazine. Today's program is sponsored by the Echo Group. And of course, thanks go to our sponsor, the Echo Group, and to all of you for joining us today and giving us your time and attention. Very quickly, before we start the presentation, let me explain a few housekeeping details. Each window on your screen can be moved by clicking and dragging it, or enlarged or minimized by clicking the icons in the top right corner of each window. Please use the Q&A area that is to the right of the slides to submit a question at any time. And if you cannot see this area, simply click the red Q&A button. To download a copy of today's slides or other materials related to today's topic, please click the link in the resources area at the upper right of your screen. And if you have any technical issues during the program, please click the yellow help button to help you troubleshoot the issue. At this time, it's my pleasure to introduce our speakers, Steve LaFleur and Joe Vigier. Steve LaFleur currently serves as the Chief Information Officer, providing oversight of agency network infrastructure and EMR development. He has been in the mental health field for more than 20 years, starting as a clinician, then managing clinical programs, and eventually supervising technology services. And of course, that's at your center in Oklahoma. Joe Vigier joined Echo in 1999 after working in a behavioral health organization for 12 years. He has a diverse background working with adults, families, and elders. The background includes case management, managing residential systems, community-based treatment teams, and drug abuse prevention. And of course, that's all that before he joined Echo. So thank you to both of our speakers for taking time to speak with us today. With that, the audience is yours.
Thank you very much, Dennis. It's good to be here today. This is Joe Vigier, Vice President of Business Development for the Echo Group. Today, the Echo Group is proud to bring you the opportunity to hear about an innovative approach to addressing the technology needs of providing behavioral health and primary health care. The Echo Group has worked with many customers on integrated care projects like the one we're going to speak to today, and several of them have been grantees of SAMHSA's Integrated Care Grant Program. Grand Lake Mental Health Center has been one of those grant awardees, as well as working in integrated care even prior to that award. Our customers' integration models have been diverse, and so have been their approaches to using technology and electronic health records to support these projects. And that's where today's presentation comes in. Integrated care means an integrated electronic health record. From the start, Grand Lake had a vision that integrating care for their consumers also meant an integrated record for their providers. In our experience, this was unique in comparison to approaches where it's been accepted that medical and behavioral health providers might use different electronic records, or other models where data is exchanged between the behavioral health record and the primary care record. In that approach, you only get a snapshot of the other person's work. Grand Lake was striving for something better. Today, Steve LaFleur, Chief Information Officer at Grand Lake, is going to help us understand what that is. I met Steve for the first time many years ago at a conference on Cape Cod. It was my first business trip as an Echo employee. He identified himself as a clinician and then told me that after the conference he was driving up to New Hampshire to Echo's corporate office for training. That was back in 1999. In those days, we didn't see too many clinicians for training. That just wasn't where the industry was at. We had just introduced Clinician's Desktop, the first true Windows-based electronic health record for behavioral health. But some of you might remember back in 1999, it was all about the billing system. That's what mattered to people. The clinical record was kind of a nice to have, and that's kind of cool kind of comment. things have certainly changed, and it's safe to say Steve is going to bring to us a very unique and valuable perspective on his work. As Dennis pointed out, Steve is CIO at Grand Lake today. He has a master's degree in counseling from the University of Illinois and is a licensed clinical professional counselor in that state. He had previously worked for another Echo customer, Heritage Behavioral Health, from 1992 to 2009, and in that role started as a counselor but moved ultimately to VP of Information Technology, and in that role played a key role in helping Heritage become the first organization in the country that was a behavioral health organization to win the Davies Award for the excellent implementation of an EHR. If you're not familiar with that award, it's presented annually by HIMSS. Steve has worked hard on progressive projects using electronic health records, and we're honored to have Grand Lake as one of our customers. We're thrilled to bring today's presentation to you, and with that, I will turn it over to Steve, and he will help you understand some of the great things Grand Lake has been doing regarding integrated care and an integrated record. Thank you.
Thanks, Joe. I do appreciate the opportunity to share a little bit this afternoon about what we're doing with integrated care as well as the integrated health record. I hope to be able to talk a little bit about Grand Lake's process in getting where we're at today and where we are planning to move, but also in that discussion I hope to be able to show some very specific screenshots of what we've done so you have a good idea, hopefully by the end of our time, what the integrated record looks like here and some of the concepts we've tried to implement as a part of that. A little bit about Grand Lake you can read, and I believe that we're just like most community mental health centers. We serve, as you can see, over 3,500 clients, adults, children. We're in the schools, as you probably are. We're in the courts. We do outpatient. We have special programs funded by the state, like Systems of Care and TANF. We have handled most of our psychiatric visits over the last 4 years with telemedicine. Oklahoma spent a good deal of time trying to implement telemedicine, and we started very early in the ball game, and we do about 1,100 telemedicine visits for psychiatric is what we were doing every month until a couple of months ago. A little bit about the process of getting to integrated care. We started about 2.5 years ago visiting models primarily in Missouri. We visited 4 or 5 sites in Missouri to see the various parts of integrated care as we started to explore it, and thought that that's where things were going, and we definitely wanted to be a part of that. But at our core, as it may be for many of you, we were a behavioral health center, and we prided ourselves on the fact that we could provide mental health services. It was the one thing that we did well. Our mission statement said the same, and we were lucky. We had a mission statement that suggested that we provided integrated care, but we just weren't sure how integrated that was going to be. And when we started thinking about primary health care, then the proverbial paradigm shift was definitely in the mix, because literally integration meant so much more. And I don't know if you're a behavioral health agency and looking at integrated care, does your mission statement even cover the idea of primary health care? Ours kind of did, and we felt like integration was inclusive. It just that it meant more than we ever thought it was going to be. In fact, it's gotten to the point where we just remodeled one of our offices, and we didn't exactly change the name of it from Grand Lake Mental Health Center, but we put up on the sign a DBA, a doing business as, and we actually now are doing business as Grand Lake Medical Health Center. So again, a big change for us and our mindset, so to speak. But we can provide all of these services, and even though it's an or statement there, we provide many of these services, and you probably do too. But probably the thing that got us moving into integrated care was this mindset of and the reality that if we're always looking at the things that we may or may not be able to do, instead of, as things come along, realizing that we may be able to add them to and be able to do these new things as well. That's what got us really started into the primary health care. Our CEO, Charles Danley, and COO, Larry Smith, emphasized from the very top this mindset of and have kept the board informed when we started 2.5 years ago. Hey, this is where we're headed, and it's literally going to be Grand Lake Mental Health Center needing to be able to provide not just mental health care, but also primary behavioral health care. So this mindset of and is very powerful. We can provide services. And again, many of us did as just behavioral health, provide services to children, to adults, do outpatient, but also the and outpatient physical health services. With that philosophy and with that mindset, we can continue to move forward. And with an electronic health record, this mindset of and, the electronic health record provides us that information on our consumers, not just their mental illness, but also their physical health problems. At least it could do that. And it could provide medications for the client, and it can be retrieved anytime, the benefits of the EHR. If you already have an EHR primarily or specifically a certified EHR, you've already got a start, because it's already probably recording medications within it or able to do that. And a lot of the certification revolved around some physical health issues. And we were very surprised when the health records, when they became certified, now all of a sudden there's vitals that's in the record now, in this behavioral health record. And BMI is in the record. Things that we were never really collecting officially in specific fields, now all of a sudden became a part of the record for us. So the certified EHR, which the clinician's desktop was a big push towards that too, that some of that data was there. And now could it begin to help us provide this primary care as well? So medical health and mental health. The thing that we realized with this mindset of and is that both services required basically staff that we had on board already, support staff, specialists, people to schedule, a reception area. Both required, diagnosis, the documentation, lab work. So a lot of these things were there, and so the only thing that we had left to do was the planning and how were we going to implement it once we accepted the fact that we were going to do it. And so that's where we began talking about what we can do to the record so that it can be fully integrated, so that both services could be provided. Both services require the prescription, both services being reviewed, the billing, both services posted. We wanted all of the services on both sides to be able to be in the record. And so it has been a push to get a behavioral health record to be able to handle primary medical care. And then in looking at the things that the record could do, the effectiveness for us was the fact that we could design a lot of the screens in the record and work with our processes. And realizing that we were going that way and that we had a record that we could develop, it very much was a possibility that a company that's providing mental health services could provide medical as well as mental health care with the same electronic record and the same or similar staff. There are various models of care of integration, and in looking at these primary 4 levels, I need to say that in this short 2.5, 3 years that we've been looking at this, we literally have looked at each one of these and been involved in each one of these models. The referral base, pretty much the way we used to do things, where we coordinated with local health providers. That's where most of us as behavioral health centers primarily do. We coordinate with the PCPs, we coordinate with the doctors. We're working with other providers doing case management. We did that. We've been doing that since 1979. The co-location with the services in the same building. We started designing out one of our buildings about 3 to 4 years ago. We actually had a request from an organization right in the heart of our 7-county area that was applying for an FQHC grant. And they wanted to put this FQHC there, which we thought would be great for our clients as well as that community. And they wanted to use our space in this community, and so we started building it out, and we were going to lease to them at that time. But they never got funded for that. I'll talk a little bit more about that later and have an interesting aside related to that issue. But they didn't get funded, but we kept building out knowing that we were wanting to integrate care and develop our records. So we kept building out and put the medical exam rooms in the very same building where we were providing mental health care as well. So the co-locations there, the consultation where the medical health providers visit primary care. Again, we had the opportunity in Oklahoma as integrated care was coming. Our state tried to fund an initiative where they were paying medical providers to see clients with a severe mental health diagnosis, and they were able to pay for 25 of our 3,500 clients initially, and we tried to do case management with that provider and work that out, but the state couldn't promise funds in the future, and we just didn't feel like that type of integration was going to work. So realizing this last one where we actually are integrated, that the FQHC wasn't coming and we were building out the space, we started basically in March 2012. We started providing primary care at that facility that we had built out and put a nurse practitioner in there that would do the medical care. So literally a client came to the reception area, and if they were seeing the psychiatrist for mental health, they turned left in the hallway when they got in, and if they were seeing the primary care specialist, then they turned right. Both of those staff were our employees. Both of those staff were working with the same record as well, which we'll begin to look at. Even in this process, and I've got it suggested there, it may not be that easy to see, but that was our definition of integration when we started, was 2 separate providers, psychiatrists for behavioral health, and then our nurse practitioner for the medical care. That was what our vision of integration was. But now even that's changed. We're at the point now where we are having one provider. It's the nurse practitioner who is seeing the consumers, and she is now dealing with both the behavioral as well as the medical. And if she needs specific assistance from the psychiatrist, he's available by consult. So he's just doing a consult basis. so that's where we're at as far as our sites. We're designing all of our sites. We've remodeled one of our sites completely and added besides the one we began in, we've now got another one that is the one doing business as a medical center, and then we're currently remodeling 2 other sites and adding medical facilities as well in there. Let me show a little bit about the record and what we had to do to the record. Here's what we're working with under our integrated medical view. The beauty of this record. Oh, just an interesting aside, I did add a picture in there, and now you can put a face with the voice. I'm not really a patient just yet of Grand Lake, but I thought I could at least slip a picture in there so you know what I look like. But our integrated medical view basically shows the provider a snapshot in this VHR view, a snapshot of where this client's at, highlighting near the top there some basic demographic information, and then there's their current diagnosis, what the status of their treatment plan is. The dark blue there is medication that they may be on, and I'm just on a test client now. And then there's icons that can be slipped in. You can see on the left that there's vital signs, and there's an icon there that suggests that on that day vitals were taken. There's an episode, and then a little bit lower, which you'll see later, the doctor or the provider can see all of the clinical service that the client has either attended, that they may have been no-showed, that they may have missed. So the beauty here for the provider is in one view they can see the status of that client either on the medical side or the behavioral health side. They can fly over something if they just want to get a quick glance at it. And here's a screen print that's a flyover of the BMI. And there's actually on this icon, you can see there's a little mark on it that suggests that they weren't quite normal. And the doctor or the provider can fly over that and get a brief look at what those are. But if they want to drill down, then they can click on and they can drill down to the very specific vital for that particular day. One of the keys in developing the integrated record for us was making sure that when we began, I suggested that we had a psychiatrist working separately and the medical provider working separately. The key for us on integration was making sure that both providers did not have to navigate too much to be able to see what the other was doing. And so literally when the psychiatric nurse was entering vitals, they were entering into the very same table and the very same fields that our medical provider nurse was entering vital information. And so you can see here's a list in this test client here of 4 different vitals. It could have been done, and they can tell by the staff person that did it whether or not it was the psychiatric or the medical side. And of course now that's not as much of an issue because we've got one provider, but still the key for us was making sure that both providers could see what the other was doing very quickly. And so here they can drill down and see at a glance the status of their vitals over, because this table is recording every vital that is taken for that particular client. And so they can see at a glance if those vitals are going up or down. I suggested that the VHR shows all activities, and I've got a couple of activities that are down here at the very bottom of the screen. We can break it out by category here, and an icon. There's an icon over here to the left under individual that suggests that they had an individual service that day. And again, they could fly over it and see that it was a therapy appointment or see what it was, and if they wanted to drill down to the actual progress note, they could do that. The circle with the red X is a doctor's appointment or a physical health appointment. We previously had them separated out, so there was physical health and then there was the behavioral health, and so the appointment and the icons were different. But again, when they popped it up, they would be looking at the same basically the same progress note, just different portions of it filled out, and we'll see that in a little bit as well. Here's a view of the medical note in our system, and this is literally our current version over the last couple of years. And when I say current because it's literally our fifth iteration of the note. We keep adding things and taking things off, trying to make it more efficient for our doctors and being able to see what they need to see. But a little bit about this note and being able to work with it. This is the view that initially both providers saw, the medical provider as well as the psychiatrist. And they could click on, you can see buttons there for vitals. That's where they would click on and enter the vitals and see it. They can see allergies. They can see meds that maybe aren't in the system but are client reported. We started real early on. The doctors wanted to see some stuff that was done at the bottom there, what was on the initial comp assessment when they came in, what was on the initial things the client reported when they came in. So we tried to make it very easy for either one of the providers to see what they needed to see to do their work. But the key is that this note was literally the psychiatrist's note as well as the nurse practitioner note. Now the nurse practitioner uses this, and you can see what we've added since we're now doing consults. We've had to add things to the note that would suggest that they're working with a psychiatrist if they need to. Probably one of the biggest pieces that we struggled with over the last year in this move to integration, and I'm sure you may have struggled with it as well, but the change in the coding structure to move from move our psychiatrists from 908 codes and having to move them to E&M codes. When we moved to E&M codes, which were medical codes, as you know, we struggled early on with our psychiatrists writing a note that was a good quality E&M note, and not necessarily the way they were documenting the 908 notes. So literally getting pushed by the system into a medical note, things that we had to start adding into the note, and this was one of them. When we really started getting was having some type of medical family history and being able to have that as part of the note. And so literally having to fill this out with this change to be able to begin to understand what are the pieces that we're going to need now that we've had this big paradigm shift for us and we're moving into medical care. What different documentation do we have to have? How are we going to bill it? Because it definitely bills differently than our behavioral health services did. And how are we going to code the records? All of a sudden, it wasn't just one specific 908 code that our doctor was using, but now based upon the level of involvement we have with that client, there could be different levels of the 99 codes. And so we wrestled with that, and being able to make those services bill out of the system was a challenge, but that's part of the full integration, was being able to bill, and indeed they do, being able to bill both of these services and now the full integrated service out of the same record being provided, not to have two separate systems set up to do that for the services we're providing. So in the note, as we add, if they need to do a review of systems, you can see there's two tabs here past the middle screen where they can do a review of systems as well as do the exam. And one of the challenges in designing a note that's efficient, that allows your staff to move through, that we found was being able to have narrative where it was necessary and being able to set things up so that especially in these narrative sections, these large narrative sections, we have templates built in If they want to use them, they can use the templates to help themselves in the documentation. But if not, when they get to a full psych exam, and here's our most current screen for a psych exam, literally to design the record so that they can see over here on the right-hand side the status of any psych exam that's been done, and they literally, I've not got another one in here, but it would show the dates over here on the upper right-hand corner. It'd show the dates, and they would be able to just click on the date and see what happened at that particular exam. But where we could add check boxes for the provider, we did. Most of the fields here you can see are just kind of a white box. Those have drop downs in there where they select appropriate responses during while they're doing the exam. This also made it a lot easier too. Having this type of setup was basically the most recent redesign. When we had the nurse practitioner now being involved in this process to make it very clear for her as well if she wanted to see what was going on with the particular client. The last tab in the note, in the integrated note, again, the provider would fill out, both providers initially and now just the one provider fill it out, but one provider can review the behavioral now as well as the medical. But they have they have the diagnosis. They both have a plan that's narrative, and here's the plan where they would be acknowledging what they did during that session, and you can see here this was the most recent edition up on this screen. The only reason I showed it was here's where they would check if the nurse practitioner, if she's seeing the person and she needs to consult with the psychiatrist, she would check this box and then note in the plan that she consulted with the psychiatrist, and here's what's happened. Now, normally I should say that with this fuller integration and the consultation, our psychiatrist still takes the opportunity the first time for the client, if they're the behavioral health, the psychiatrist sees them for the first initial visit and would progress note on this very note. They would still progress note what they did, but they're the ones that may start the initial medication and why they're starting the initial medication. And then the nurse practitioner that's involved now would pick it up pretty much after that first visit, unless there was a primary medical concern. But the way the integrated visits work now, they come in to see the nurse practitioner, who primarily then is reviewing the whole case, whatever the medical issue is that brought them in, or if they came in for the psychiatric side, she'd be reviewing the medication and then asking about medical. If they come in for medical, then she's also reviewing the psychiatric if they have psychiatric. So both pieces are dealt with by the provider, and then based upon what's needed, the provider calls the psychiatrist if they have to. This was probably one of the biggest challenges, was having a diagnosis screen where the medical provider would have access, and this was one of the challenges that we found in having this record be integrated. On the behavioral health side, we always had a diagnosis. The client always had a diagnosis, and if they were schizophrenic, it was an open-ended diagnosis, and as long as we were providing service, it was the same diagnosis that was attached to the service almost every single time that the client was getting services. And so the software would kick that out, no problem. But now with medical, the reality was that all of a sudden a visit could entail not just one diagnosis, but 2 or 3 diagnoses. And this is probably the 4th iteration of this screen, was now how do we attach 4 diagnoses to a billable service, and not just 4 diagnoses for a service, but maybe 4 different diagnoses for another service 2 or 3 weeks later. So it just was a challenge to be able to integrate, being able to have more than one diagnosis or one primary diagnosis, and then now that we've got just the one provider, for that provider, and I don't know if it's clear, you can see it, but what we did was in the drop down here, after each visit, when the provider's documenting and they have to select a diagnosis, you can see that in that drop down. I hope it's clear, but we've set that drop down up so that they can see any current open diagnosis. And so usually the behavioral health diagnosis is open-ended, doesn't have an end date on it, and most of the medical diagnoses have an end date a lot sooner than a behavioral health one, as you know. So, but if there was a diagnosis that the doctor had put in of diabetes and it was open-ended, then it would show as an open-ended one up at the very top. And then you can see the ones that I think are listed as 3B and down. That's the whole list, at least the list that we started with. That's the whole list of possible primary care diagnoses that could be in there. So we wanted the doctor to be able to select the diagnosis that was open if they were dealing with either side or a chronic condition. Those are the ones that would show up near the top. But then if the client had come in for maybe just a cold or a sore or something, they would be able to go down and select any other primary health diagnosis. It was a challenge to get all this in one particular place. Initially, we had them separated out, and we struggled with trying to integrate it so that they could see it in the one view. But now for the provider to be able to, the one provider to be able to see all the diagnoses, select which diagnoses are appropriate for this particular visit, was a big boost for us in helping speed things up, as well as having that provider be able to provide that complete service. On that screen, I go back. On that screen, you can see there's boxes down there in the lower right-hand side where if they need to make referrals, this was another part of the integration so that again, all services that are going to be helpful for this client could be seen in the same record, and literally the way we've got this set up on any particular progress note that they're on. If a referral was made, they could click on that and they could see the date of that referral whenever it was made, no matter what date of service was that the referral was made, they could see that. And those referrals could be to outside agencies that could be tracked, or they could be to internal programs. You can see we've got here we've got a wellness or a movement program. We've got a smoking cessation program. Referrals are made literally from the progress note into those particular programs. That again, another help toward integration. Another big piece of the integrated process is the labs. Again, part of a certified EHR is being able to have labs available in this sense within them, and our labs can be ordered, at least right now, from this particular screen. The labs are ordered, and then a report is run, and they collect what they need to and send it along to the lab. One of the exciting things that we're glad ECHO's been working on and vendor for us has been the more electronic interface, and we're real close to having that. Now, have been working with it, but this is what the interface looks like now. And the challenge for us is getting this at 7 different sites with different staff folks, but literally the interface will be able to order the lab from the record, and the results will come back electronically as well into the record. We have that now with the medications, and that's been very helpful for us. we're really excited about it getting to be the labs getting more fully integrated than what they are now with the results coming back electronically. I mentioned that the medication was integrated. This is probably, let me just pop this screen up here. We've also, with this mindset of and, it's always, what else can we be doing to integrate our services, to integrate our record, to integrate the pieces that our client is having to interface with. And this is within our system right now to work with a pharmacy where it is truly integrated, where our clients now come to our site and they pick up their medications literally at our site. And once they're picked up, the pharmacy that we're working with can scan. Our staff scan the meds when they come into our facility, and then the meds are scanned when the client picks them up, and they have a record of all of this. And within our record, they know as well by our working together and our integration, they're able to know what has come back in our e-prescribing system because they're handling 95% of our medications for our clients. And literally, the most exciting part of this for us is that we'll know where we didn't know in the past before this integration. We'll know when a client has not picked up their meds. And literally when they've not picked up their meds, if they haven't picked up their meds within 15 days, that'll be our cue to be thinking, hey, this client is now non-compliant with their medications. Is there a problem going on? There's a possibility that they're out of their meds, they're not taking them because they haven't picked them up, and consequently they could be meeting medical necessity to get back into the doctor and dealing with what's going on, or a cue for the clinician to know. But literally to get reports from the pharmacy, since they're tracking this information, to say, hey, you've got these clients that haven't picked up their meds within 15 days, and which meds haven't been picked up, to be able to work with the client to get them back on their medication, hopefully avoid some type of crisis that could be coming up. A couple takeaways, maybe seem obvious, but again, just thinking about some of the things that we've wrestled with and tried to work through, and gotten on the other side of now and said, wow, we've still got a ways to go, but these things have been helpful. The idea of the clinical and having an integrated record, the key concept and the mindset of and is to literally have as much information as possible, as much personal health information on that client in one record that is accessible by the provider. We're working very closely right now with the vendor and with a local health information exchange in Oklahoma. We're hoping to be, at least the health information exchange is telling us that we'll be one of the first behavioral health centers to be able to have information in the health information exchange. But literally at that point then, our record would have access to even hospitalizations, direct ER visits. So again, the concept of, even that information is possible within a record through an HIE. So get as much information. Integrated care does truly mean an integrated record where it's all there. Financial, we were really worried about, as you may have been, with the code changes and whether or not we're going to be able to pull off E&M codes and not knowing from a behavioral health side how these medical notes should be coded a certain way. We have hired a coder, which is the first. We've never had a coder before, but literally this coder is going through our progress notes, and what we had anticipated most of our codes to be, for the first 8 or 9 months that we were doing this year. As she started reviewing some of those, a little bit late to be billing those out now, but the ones that she's doing right now, we're finding that we were undercoding a lot of our services, and we should have been getting credit for the quality of documentation that we were doing. We were just having that assurance and that reinforcement that no, your note's good enough to pass muster for a higher level of care has definitely helped us to maximize our integration initiatives, but maximize as well the funding of those initiatives. Goes without saying that for the consumers to have integrated care, to literally be able to go to one location and get their behavioral health services or behavioral health needs met, to get their primary medical care if that's needed, as well as to get their medication, whether that's their meds for their behavioral health or their medical health. Just numerous reports from the clients of how beneficial that's been for them. And just having that available for our clients that maybe have never gotten the primary care or never went to the emergency room, or that's where they always went, or when we would refer them to the doctor to not know if they ever got there. Now to be able to deal with things. Just one brief story. Just our provider had noticed just recently someone just in one of our facilities that just was, the way they were sitting, thought that something was wrong, and went and talked with them, and ended up finding something very wrong, and was able to help that person, and they've just been very thankful. But just to have the mindset now that we're dealing with more of the whole person than we ever have. I suggested briefly or early on the interesting side with the FQHC. The FQHC, they hadn't got funded. They hadn't got funded almost 4 years ago now. All of a sudden last week got a notice that they were funded. And so they were wanting to say, is that facility still going to be available? We intend to still lease in that facility, and then we'll be in more of a cooperative thing. But the exciting thing, and a piece I wanted to share about this when I talk about an integrated record, that FQHC, because they're an initial startup, they've seen our integrated record, and they've asked the question, is it possible for us to have the same record? And just that statement to lead us to believe that, wait a minute, this is now a medical, one that's thinking just medical, and they're thinking about integration, and they're thinking about maybe even using a behavioral health record to work with their clients, because they'll literally be in a building that we've already built out, but they'll be in a building where people are getting behavioral health services. But the exciting thing is this group that started with just thinking and focusing on the primary health care, they're now thinking about integrated care to the extent of even an integrated health record that they've seen, and that's actually doing the work that they intend to do. So, again, thank you very much for the opportunity to share, and I'll turn it over to Dennis, I believe.
I'll jump in, yeah.
Questions. Yeah, thanks, Dan.
Let me jump in now with some questions from the audience. Real quick, Steve, while you're wrapping up here, exactly what is the scope of the medical services that you provide at Grand Lake?
Good question. It's very primary care. We're not doing. We had an X-ray machine in here at one time that we had on loan from the hospital, but that didn't work out. We just weren't doing that, so we aren't doing X-rays. We aren't doing, significant procedures, very minor procedures, stitches, lancing, but we're not setting bones or anything like that. If it needs much more extensive, basically we're identifying things that maybe had not been identified, like sugar levels, lipid levels. We're doing a lot of labs. So again, I'm not a medical health person primarily, but I would say very basic medical care.
Okay. Another good question. Are behavioral health providers required to implement an EHR system? Joe or Steve, if so, what's the deadline? I don't think there's a deadline, but would you like to, either of you like to take that on? I think I know the answer too.
Well, I'd share a thought or two on that. I think there is no firm and fast requirement that you can really speak to or point at that, on line X, Y, and Z, you are required to utilize a record. And that said, many accreditors are increasingly looking for electronic health records. We get very good feedback when our customers are reviewed in that regard. There are also obviously meaningful use initiatives out there that really push organizations to become more electronic in how they do business and how they manage their clinical record.
Yeah, Joe, let me speak a little bit about the meaningful use. I mean, that's probably been the most exciting thing about having the electronic record and having a certified one is that we were able to apply for meaningful use funds, and literally we focus even some of our staffing. I mean, we're hiring nurse practitioners instead of PAs because the nurse practitioners are eligible for those funds. But literally, as soon as we can, we attest to having a certified record and get the first wave of meaningful use funds, a little over $20,000 for our providers. Those dollars over the past couple of years have gone a long way to helping us develop this integrated record.
Okay. I guess one other thing I'd share is if you look at the major federal initiatives that have evolved in the last couple of years, they really do speak to a much more integrated approach to providing care, a much more coordinated approach, and the focus there is improving quality and reducing cost. One of the ways coordination will occur is through technology. A lot of leaders I speak with in the behavioral health world, people who run organizations and run big and small organizations, say to me, if I don't have a strong technical platform to conduct that kind of coordination, to exchange CCDs, for example, clinical documentation architecture records, I am less competitive in my marketplace. I am less viable in the community that I'm trying to serve, and I may not be the preferred partner with these other folks and the preferred provider anymore. So to continue to maintain a viable organization, I need to do this. So again, not a regulation, but a progressive, intelligent thing to do to maintain the position and the mission of your organization in the view of many of the people I'm talking to.
And I also believe that we're already starting to report in our billing for these E&M codes whether or not we have an electronic record, because I believe that Medicare is going to start cutting. I don't know if it's 1% or 1.5%.
Well, it's 1%, I believe, Steve,
the
first year
if you're not
in
using
2015.
an electronic record. Yeah, and it's like
That's
a penalty
correct.
if you're not using the record. And so I think that, that suggests to me that there is a big push that we should be using electronic records, and you'll get penalized if you don't. So
sure.
Okay.
Well, that's good. That's a good wrap up. So it's not required, but especially for Medicaid or Medicare related services, there will be, unless they put it off, there will be a 1% deduction if you do not submit electronically by 2015. Let's move on to a couple of other questions. Can integrated care be effective between two different organizations that use two different EHRs? the question is using an integrated, I guess, identical solution absolutely essential between like primary care and mental health?
I think that most of these primary care, I know even on the PBHCI grant that we have for integrated care, that a lot of those are done with more of the collaborative relationship, maybe with an FQHC or with a primary care provider, and they have two records, and it probably can be done with a lot of case management, and it's probably a big challenge to ever get the two records to speak to each other. If they're certified, eventually they're supposed to be able to speak with each other, or if there's some clearinghouse for that information. But I think in most cases it's just a little bit of it's more work entailed because if you want the provider maybe at the behavioral health center to see the medical, they either need a copy of that record on paper or information from that record needs to be entered into the behavioral health record. That medical information needs to be entered into that behavioral health record, and then you're kind of in a double entry situation. It's getting entered electronically somewhere else, and it's getting entered electronically again, for the other party to see it. So it probably can be done, and in most cases people are doing that, but the integrated record just shortens a lot of that up.
So it's a matter of efficiency, and I know that people are looking into means of exchanging some of the documents, across systems like the CCD, but maybe it's not quite there yet. Question: Did you?
I think.
Yes, of course.
Now, the other aspect of the dual record is what we see and observe, and some of our conversations with folks at Grand Lake early on were about this, is does it have to be a different record because the functionality doesn't exist to do both in one? And we hear a lot of people express that belief strongly, that behavioral health systems don't have the medical chops, if you will, and medical systems don't speak to treatment planning or other core architectures that are near and dear to the behavioral health mindset. And one of the things that I think is compelling in the work Grand Lake has done is they're proving out that you can do it in one record if you want to, and there are care benefits to that. So that's one of the interesting aspects of this is some folks have had to use two records because they believed there was no other way. And I guess we were keen to demonstrate there is another way. And if you want an integrated approach, you can have it.
Okay. Quick question, yes or no, Steve, did you qualify for meaningful use funding as a psychiatric facility or medical facility, or did you have to do it as eligible provider only?
We did it by our eligible providers in the Medicaid.
Yeah, and to that question, I'm sorry.
Go ahead.
I was going to say to that question, I know that just last week there was another bill introduced in Congress to consider the question of whether or not to add psychiatric facilities and, inpatient treatment facilities, mental health and addiction to the meaningful use. But right now, the only availability for those funds is to individual eligible providers,
right.
like
and that
physicians,
was really the
nurse
key
practitioners.
Right. And that was really the key, was our psychiatrists were eligible and our nurse practitioners, I mean, it literally, for us, has affected hiring. If it's between hiring a nurse practitioner or a PA, we're going to hire a nurse practitioner because they're eligible for meaningful use under Medicaid.
Okay. Very briefly, our last question here. Have there been any legal issues surrounding the use of an integrated record? One person says they're a co-located program now and want to move towards an integrated record approach, but behavioral health staff, assuming mental health and addiction treatment, are resistant due to patient confidentiality issues. How have you handled that at Grand Lakes? And, I don't know if Joe has any comments on the broader issue. Again, confidentiality.
Yeah, we've not changed much policy. I mean, we've always had policies to protect privacy and patient confidentiality, and the record can be set up to shield people who don't belong in certain parts of the record to see some of the information. But pretty much clinically, through the VHR that we have, we can show the pieces that for your position you need to be able to see. And then our policies cover, don't go in there if you're not supposed to be in there, and but we've not run into any legal issues policy-wise. We've got a compliance officer that reviews all the stuff that we're doing with this progress note and where the information is in the system. So we've not had any issues along that line.
Okay. And with that, I must say we've got to wrap it up. Thanks to both of you, Steve and Joe, for a very informative presentation. It's unfortunately all the time that we have today. Many thanks to Joe and our sponsor, the Echo Group, for making today's program possible. I'd remind everyone that there's downloads in the resources area right at the top right of the screen. And, of course, finally, thanks to everybody who's joined us today for participating and for your fine questions. We hope you'll join us in the future for another behavioral health care webinar. Otherwise, that concludes today's presentation. Have a good afternoon.